All right. Welcome, everybody. This is being recorded for later viewing. I'd like to introduce myself and our team. But first, welcome to our Tackling Child and Teen High Body Weight Conditions. This is our first virtual event, so thanks to everybody for attending. I'm Dr. Roy Kim, and I'm going to be moderating the event. I'm a pediatric endocrinologist and part of the Be Well team, which you will hear more about. And like everyone here, I'm really passionate about helping young people and their families contend with this problem of high body weight. And with me are other Cleveland Clinic experts, and we are all dedicated to helping you and your child contend with this condition. We're here to talk about state-of-the-art updates about treatment, about the condition itself, when to be concerned about your child's body weight, and we're going to talk more about the Be Well Kids program, what it's made up of, who the team members are, and what we do, and what our philosophy is. And most of all, we really want to give you a great sense of hope and optimism that your condition is very treatable, and we're at sort of a new era of treatment. So first, a word about today's format. I'm going to introduce each panelist. They will give you some background information about themselves and then present a little bit about their area of focus. And then most of the program will be devoted to a Q&A session. And actually, throughout the talks, if you have a question, you can enter it into the chat. Please address it to everyone, and it will appear, and we will address them by the end of tonight's program. And then also during the Q&A itself, feel free to enter more questions as they arise. And some of them may turn out to be addressed during the course of the speakers' presentations. Okay, with all of that said, I am going to first introduce our first panelist, Dr. Lina Alkhalid. And Dr. Alkhalid, if you'd like to say just a couple words about your background and then your presentation.
All right. Well, thank you, Dr. Kim, for the introduction, and thank you for having me today. So my name is Lina Alkhalid. I'm actually also one of the pediatric endocrinologists and obesity medicine specialists here at the Cleveland Clinic. And one of my main areas of interest, which is very near and dear to my heart, is the childhood obesity management and evaluation. I'm one of the providers at the Be Well Clinic. And for people on the call who are not very familiar with our program, the Be Well Clinic is a comprehensive weight management program where families meet with a group of healthcare professionals with expertise in childhood obesity. Namely, they usually meet with a medical provider, with a dietitian, a physical therapist, and a psychologist. We typically see children between ages 2 and 18 years, and we work with them and their families to develop strategies and create plans for a healthy lifestyle changes in hope to improve their quality of life and enhance wellness altogether. We try to see our patients on a monthly basis, and our family-centered approach actually strives to create this lifelong healthy weight. Generally, our approach is usually in line with the American Academy of Pediatric guidelines and the pediatric obesity algorithms. But generally, this actually includes a thorough assessment for different causes of obesity, whether it's related to genetics, hormonal, or just the multifactorial exogenous obesity that we're very familiar with. We try to develop and implement usually an evidence-based treatment plan for our patients with obesity. So we try to have like individualized treatment plan for each patient. In addition, we try to diagnose and also treat other obesity-related comorbid conditions when it's appropriate. And I'm gonna go ahead and share a slide to kind of just walk you through like how we actually approach our patients and how do we manage obesity in general. So And as you see here, this is actually the management of childhood obesity generally happens in a stepwise manner. So we always try to start with a very intensive lifestyle training, so healthier lifestyle habits, working on their diet and exercise, their sleep, their just even like if there's any issues with stress as well, we try to address that. If that patient is taking any medication that can be contributing to their weight gain, we try to adjust these medications when appropriate. In certain patients, when medications are needed, we can always try to discuss the use of pharmacotherapy or medications for weight management. And for our patients with severe obesity who start to develop comorbidities, or even before, we actually discuss with them, if needed, the use and the implementation of bariatric surgery for weight management. And just to note, although this is a stepwise management, this actually can change just depending on the patient and the severity of their disease and the presence of comorbidity, whether actually if the comorbidity is already there at the initial evaluation, we might need to skip some steps and just go to more aggressive therapy. So this is what we do kind of in a nutshell, but I'll leave it to the other panelists here just to give you more details about what they do as well. I will stop sharing.
All right, thank you, Dr. Al-Khalid. And now we will hear from our surgeon, Dr. Andrew Strong.
Hello, my name is Andrew Strong. I'm one of two bariatric surgeons that does do pediatric, metabolic, and bariatric surgery. I do want to take a minute to explain those two terms. Bariatric surgery is the term that most people are familiar with, which is surgery that is done to promote weight loss. The way that we like to think about it in our department is more metabolic surgery. There are a lot of different effects of surgery that include weight loss, but also can improve a lot of other different aspects of health. And I think one of the most important things in the pediatric population is what it can do to prevent progression of other diseases in the future. And so when thinking about surgery as a solution to or intervention for all of metabolism, I think is a better way to think about it. And I try to use that term pretty liberally. We are at the Cleveland Clinic a accredited comprehensive bariatric center, which means that we are specially credentialed to do pediatric bariatric surgery or pediatric metabolic surgery. And I will welcome questions later, but I did want to share a couple of pictures of what the surgery anatomy looks like, because that can be something that can be very confusing. So we have two main operations that we do. The first one I'll start with is what's called the gastric sleeve. We'll go through some of the indications of this later, but this is an operation that conceptually is pretty easy to understand. We remove about 2/3 of the stomach. We do that using a stapling device that seals off the stomach, and we actually remove that portion. This is the most common operation that's done in the pediatric population and in the adult population, actually. The other operation is called a gastric bypass. Typically, I like to explain this more as a rerouting operation, if this pointer is going to work. To get to this picture here, I'm going to start looking over here. We use a stapling device again and make a small pouch out of this upper portion of the stomach here. And then we go around 1/3 of the way down the GI tract and make another division there. This downstream part here is what we bring up to connect to that stomach. And then we have to reconnect this down here. So you end up with two new connections. One is there and two is here. And that's how we get to this picture over here. So nothing is removed, but food does not pass through this part of the stomach or this part of the small intestine. And this turns out to be one of the most metabolically important parts of the entire body, is this part of the small intestine right here. which is completely bypassed. Not to belabor any more of the details about surgery, I'm happy to answer questions later on as we get into that portion.
Thank you, Dr. Strong. That was very interesting. And next up is our dietitian, Ms. Margherita Shook.
Hello, everyone. My name is Margherita Shook, and I am one of the pediatric dietitians who is part of the Be Well program at the Cleveland Clinic. My focus with our patients is on general healthy eating and how to make small changes that will stick with not only our patients, but with their families throughout their life. Balanced nutrition is essential for proper growth and development, and it is just as important to get enough nutrients in our diet as it is to not get too many. We typically start every appointment during our Be Well clinics with a diet recall to understand what exactly the child is eating and drinking throughout the day, paying attention to portion sizes and potential sneaking of food, which is much more common than we think in our childhood population. We also come up with 1 to 2 goals at each visit for the patient and their family to work on when they get home. Some typical goals that I have for families is eliminating sugary beverages, decreasing fast food, or simply adding at least 1 new fruit or vegetable to their diet. Our goals are usually always most successful when it is a family approach and everyone in the home makes the changes so the child does not feel excluded. We talk about that a lot during our clinics. We really focus on the My Plate model, which is the official symbol of the 5 food groups, which are grains, fruits, vegetables, protein, and dairy. The My Plate model is a great reference for families and children because it emphasizes the importance of a colorful plate and increasing variety in the diet. We also discuss additional tips for tackling obesity, like using a smaller plate when you're offering food. So some kids use a 12-inch plate. Maybe we try using a 9-inch plate instead to control portion sizes. And also eating slowly by putting your fork down in between bites and chewing your food thoroughly to avoid overeating. Many children resort to more of a grazing pattern of eating rather than eating 3 meals per day and maybe 1 or 2 snacks. So it's important to change these behaviors early on to avoid eating a lot of empty calories and making your meals count, especially at this age. As a pediatric dietitian, my biggest goal is to help families and patients understand why nutrition is so important starting in childhood, no matter how young they are, and trying to help them navigate through any barriers along the way. And as everyone has said, I'm happy to answer any questions at the end.
Right. Thank you, Margherita, for that interesting presentation. And now we will be joined by Kathleen Finnan, our physical therapist.
Hello, my name is Kathleen Finnan. I'm a physical therapist with the Cleveland Clinic Children's Hospital, and I work at our Be Well Clinic at Fairview Hospital as well. Physical therapy is a type of treatment that helps you move better and may relieve pain. It also helps improve or restore your physical function and your fitness level. The goal of physical therapy is to make daily tasks and activities easier and to stay healthy. Physical therapy treatment should include flexibility exercises, including stretching with proper technique and focused on your needs to allow you to move more easily, strengthening exercises to improve your coordination and reduce stress on your body, posture and body mechanics education, learning how to use your body more efficiently while performing everyday activities, even at rest, to prevent injury. And gradual endurance training, which includes small increments of physical activity to improve your body's ability to tolerate increased activity demands. Physical therapy promotes being physically active. Physical activity means moving your body and using your muscles and energy more than you do when resting. Daily physical activity will benefit your physical, psychological, and social health. It has shown to help children and adolescents improve cardiorespiratory fitness, build strong bones, control weight, reduce symptoms of anxiety and depression, and reduce the risk of developing health conditions such as heart disease, cancer, type 2 diabetes, osteoporosis, and obesity. It is also one of the best ways you can prevent or improve many chronic conditions such as pain. Children and adolescents should do 60 minutes or more of physical activity daily. Most of the children who attend our Be Well program initially are not getting enough, even that much exercise over the course of a few weeks. Strategies to help them get started are, for example, walking, just starting out by walking 10 minutes, 3 days each week. Examples of this could be walking to and from school instead of getting a ride, or walking the dog around the block. Plan family activities that involve physical activities such as a hike, swimming, bike rides, miniature golf, or bowling. Decrease sitting or relaxation time, including screen time. Aim for less than 2 hours per day and break up any sedentary time every 30 minutes. Include exercise during television time, such as crunches, wall push-ups, or marching in place. And then increase moving time. Be fit. The acronym FITT, frequency, would mean the number of days per week you're going to exercise. The intensity would be I, either low, moderate, or vigorous intensity. The type of activity, is it going to be aerobic, strengthening, or bone strengthening? And the amount of time you're going to exercise, which all children should aim for at least 60 minutes each day. Often people prefer to exercise with others. It makes one more accountable and makes exercising more enjoyable when done with a friend or family member. Cleveland Clinic Children's Hospital Therapy Services has started a group exercise program for many of our patients called Gym Class Heroes. The children exercise in a group setting with 2 PTs and a rehab aide alongside their peers. Gym Class Heroes is offered at a few of our sites in the area, and it runs weekly for 8 straight weeks. Pre and post fitness testing is completed to measure gains made during the group class. Participating in community or school-based activities or sports is also strongly recommended, as these experiences and opportunities are greatly beneficial to the child as a whole, contributing to not only their physical well-being, but socio-emotional as well, building friendships and learning to work towards a common goal as a team. So that's sort of my role as a physical therapist in the Be Well program, and I am available to answer any questions as well later in the webinar.
Thank you, Casey. That was really interesting to hear about the Gym Class Heroes program. Next up is Dr. Leslie Heinberg, our behavioral health expert.
Thanks, Dr. Kim, and thanks everybody for joining us this evening. I am a clinical psychologist at the Cleveland Clinic on main campus. I am also the vice chair of the Department of Psychiatry and Psychology at the Cleveland Clinic. I see the patients that are adolescents that are in our bariatric and metabolic institute, but the Be Well program has embedded behavioral ped psychologists that work with their patients. But I'm going to just share a couple brief things. So the first part is oftentimes people just wonder, why is my kid seeing a psychologist for something like obesity? And what does this mean? Do they think that there is something psychiatric going on? And so I like to just explain why behavioral health is just an important part of the multidisciplinary care. So the first thing just to know is that as obesity becomes more severe, or as BMI becomes at higher rates, there is a risk for some psychosocial difficulties that increase. And on the psychological end, that might be an increased risk for depression or anxiety. sometimes disordered eating, like binge eating disorder, but there can also be some of those more social difficulties. A lot of kids may deal with teasing or difficulties around body image or just self-consciousness about their weight. As you've heard from everybody else here, obesity interventions require lots and lots of change. And as adults, we know that changing our diet is really hard. Exercising is hard. Even going to bed on time and not binge watching Netflix can be really hard. So for kids making these changes, oftentimes you need a lot of support. We can make good recommendations, but psychologists can help kids, adolescents, and their families be more successful in making change and adhering to these things. If we have to change our diet, that's really hard. It's hard to keep up. When we think about our kids, they have to, really keep it up for decades and decades. And the last piece is that although all of our obesity interventions can lead to significant improvement, there can be a lot of variability. Some families do exceedingly well, some really struggle. And so oftentimes that psychologist can be an important part of figuring out how to optimize those outcomes. The other piece I think is really important is when we think of weight loss, and maybe this has happened when you've talked to, say, your pediatrician, we have sort of simplistic views, unfortunately, that it's just calories in versus calories out. And if you eat less and exercise more, you're going to lose weight. And that really is the tip of the iceberg. And there are so many things that we think of that play a role in that. And on this slide, I'm sharing a whole host of medical conditions, metabolic conditions, but things that we think about around behavior change. This does not happen in a vacuum. We don't just eat because we're hungry and stop when we're full. There's lots of social components and family components, and people eat because they're stressed. People eat because they're bored. They may find that food is a comfort. It helps them cope with problems. There's cultural aspects. So having this multidisciplinary team, including behavioral health, I think is really important to address all of the things that are underneath that tip of the iceberg. And like everybody else, I'm looking forward to the conversation and answering people's questions.
Thank you, Dr. Heimberg, and thank you to all of the panelists. It was a really interesting overview, and it really illustrates that it takes a team to be effective in treating this extremely challenging condition that affects every dimension of our life. Now, we don't have any questions that have come in through the chat, but we were sent questions ahead of time from attendees. So why don't we start with those questions to make sure that we address those, and then we'll see what comes in through the chat. But the first question that we received, of a quite general nature, relates to what really causes obesity. Seems very complex, but at the same time, it should be simple. I'll direct this question to Dr. Alkali.
Right. So yeah, as you said, it sounds so simple, but however, this is very, very complicated. And that's how we know now, actually, we identify obesity as a very complex disease. So what that means, there are so many factors. A lot of these factors we know we can control, but the majority actually there's a lot of unknown and a lot of things that we cannot really control most of the time. So just few actually of these risks for weight gain, I would say, and generally actually this even starts before the child is born. It's actually even during conceiving. So if mom had any issues with insulin resistance, that would actually increase the risk of weight gain in the future for the babies, whether the baby actually was born small for gestational age or was actually too big for gestational age. Later in life, the first 1,000 days of life, as we say, these are very important. So there are so many factors that could be actually contributing to this weight gain. whether it's actually how many courses of antibiotics they've actually received during their life. Are we using bottle to feed are these kids bottle fed or breastfed? When did we introduce our solids, the solids for the first time, at which age? So actually it was found that early introduction can cause actually a lot of weight gain later in life. I'm trying to think about other causes throughout the years. Actually, even their sleep pattern that actually can affect their weight gain later on, introduction of processed foods that can change their healthy bacteria. It's the paternal also feeding behaviors. If we are forcing our kids to eat later on, if there's also, like, very importantly, if there's any family history of obesity, this increases your risk of obesity. For older kids or adolescents, we have to look at any stress levels, because we know now that chronic stress can actually increase the risk of obesity. And certain medications, as we said, can cause obesity as well. So what I'm trying to say, and I'm just mentioned few of these causes, but there are so many causes. And I don't think we have enough time to go over all of this. But this is actually what makes it a very complex disease. And this is why we have to explain this to our patients. It's not just eat less and move more. There are so many things. It's actually even the environment that we live in. It's more of a weight gain promoting environment, like being exposed to certain viruses, chemicals in the air pollutions, etc. So yeah, I'll stop here because it's a very long list.
Extremely long list, and really highlights how complex this is, and therefore it's not easy to treat. So in the Be Well program, really the foundation is lifestyle changes, information, and behavioral health assessment. Dr. Al-Khalid, I'll direct the next question to you also. When is it a hormone problem? Under what circumstances do we think maybe it's a thyroid issue or other hormone issue that could be treated? Because saying this figuratively, but if I observe my child, they don't eat any different from other kids. They're similarly active to other kids, yet they're gaining a lot of weight, and other children do not have to contend with that.
Yes, this is actually a very important thing to evaluate for. Generally, when there is a hormonal issue, we have to look at other parameters of growth as well. So as pediatricians, we all evaluate our patients and we look at their growth charts. So generally speaking, whenever we see a kid that's actually just gaining weight, but his linear growth is not really growing much in height, his linear growth just kind of plateauing, this is very concerning for us as pediatricians and also as endocrinologists. Generally speaking, when actually there's a significant hormonal issue that's causing this weight gain, whether it's a profound hypothyroidism or a thyroid issue, underactive thyroid, whether it's actually excess cortisol that you have in your body, that's known as Cushing's. So a lot of these kids, when we look at their growth charts, we will see that these kids are only gaining weight, but they're not growing well, like in terms of their height. So that would be maybe our main things to focus on, just to kind of make it very simple. This is one of the things that we look at when evaluating these patients. Yes.
Great. Thank you, Dr. Al-Khalid. We have a couple of questions related to physical activity. So I'd like to ask Kathleen Finnan, what daily activities should I as a parent be doing with my kids? And how do we engage with them and keep it fun?
So I think trying to find motivating activities that they're interested is half the battle. Many of the children who come in to Be Well love to draw, or they love to read, or they love to do sedentary type activities. So really trying to find out what kind of physical activity they're interested in, such as maybe swimming or biking, even just going for walks around the block, starting small. We're not going to, I'm not, when I make goals the first time I see the patient and they're not doing anything for exercise, I might just say, well, how about let's try twice a week, we go for a walk with mom and dad around the block. So just starting slow and really just trying to get them to be up and more active throughout the day, and really decreasing their sitting down or their relaxation / screen time throughout the day. Because I'm sure we all know that the screen time is well above where it should be. So, asking them to participate in doing chores around the house is another way I try to introduce more physical activity, because they're up and moving their bodies and they're not sedentary. They're not sitting down watching TV or playing a video game. I will even allow like some of those virtual reality video games as part of exercise, because those really will promote quite a bit of activity and movement while the children are playing those games. But really, trying to just start small and getting them to do little things each day. And like I said in the beginning, trying to find something that's interesting to them, and then taking it out into the community and seeing if there's a swim team or swim lessons, or maybe they're interested in dance. They can take some dance lessons. There's no set physical activity for each child, because they're all going to have different interests. But trying to think of that goal of an hour of physical activity every single day is really something to sort of keep in the back of your mind.
Dr. Heinberg, what are strategies to motivate my team to move if they're really not interested in it?
So, as I'm sure any parent with a teen recognizes, that getting into a battle of wills with your teen is oftentimes a losing proposition. And so rather than nagging or saying, hey, did you do your exercise goal? Did you, are you doing this? Really think about engaging in things, as you just heard, with your adolescent, making things a family activity. Not everybody else is going to kind of stay in and watch TV, but you need to get onto the treadmill. And thinking of activity as not exercise, not going to the gym, getting on the treadmill, but things that just help us move. So whether, you just heard, if they like video games, thinking about some that are more physically active. If they, like spending time with their friends, planning a activity with their friends that is going to be more active versus more sedentary. Suggesting that the whole family is going to, go someplace and walk, even if it is indoors. If they like to go shopping, well, we can walk around the mall. If they like going to a place that to grab a coffee, let's find some place where we have to walk first. So I would disengage from it's time to exercise. You promised, that nice PT and the Be Well program, you're going to do this twice a week, and then it becomes a to-do, and make it more of an activity. And I think, as soon as it becomes homework, it's really likely to not get done.
Thank you. Great insights and practical suggestions too. So thank you for that. And we also have some questions related to nutrition. So for Margherita, one question we received was, what type of nutritional foods should I be giving my child that are fun and tasty?
That's a good question. So a lot of times we try to be creative, especially when kids are more picky eaters. So maybe we talk about different fruits. If your child does not like any fruits, cutting them up in different shapes. Typically kids go for fruit over vegetables. We also talk about how we can maybe hide some vegetables in different recipes, adding it to smoothies. And I usually really involve the child as well in these decisions when we talk about getting creative with recipes, ideas for breakfast, ideas for lunch, so that this way they're on board as well.
Right, that can frequently be a challenge, the fussy eater who doesn't want to change things. And that's hard for young people and grown-ups too. So thank you for that, Margherita. There are a couple of questions related to surgery. So these are, the first one for Dr. Strong is, at what point do we start considering surgery for a child?
I think that it really is a great question, and one that really I think we all come to a conclusion in some ways independently, but also jointly. What I will first answer is that what we know about surgery and outcomes in terms of weight loss and resolution of other diseases such as diabetes or high blood pressure is that surgery earlier leads to better results. And so there are some guidelines that we use, which are sort of a starting point to say when might a child be eligible for surgery. And these are guidelines that are jointly made by a number of different groups of physicians, including surgeons. But there's no magic BMI, magic weight that we say, oh, medication or other interventions are not going to work and surgery is the only answer. What I don't want to do is introduce surgery as a final answer or a last resort, because I think it exists more in a continuum of care where medications and other interventions come alongside during, before, and after surgery. But there are some specific guidelines. In adults, we use BMI as a cutoff. It gets a little more confusing in the pediatric population because we're using percentages of 95th percentile. It becomes a mouthful. But if you are over 120% of the 95th percentile based on your height, then you would be a candidate, or if a BMI over 35 with weight-related comorbidities, or a BMI over 40 kilograms per meter squared.
All right, thank you, Dr. Strong. And there's also a question related to sort of the practicalities about surgery. How long is the operation? How soon can a child go back to school?
Also, great question. So surgery is surgery. It does involve incisions, which do involve some degree of pain. The surgeries we do are done laparoscopically, which means I use small instruments that are on very long sticks. So I have, if you imagine a pincher at the end of a 1.5 foot long instrument, that's what I'm actually using to do the surgery. And that means that the incisions are usually only about 1 centimeter or 1.5 centimeters in size, and there's a few of them in your abdomen. What that translates to is pain is usually a lot less than if I had to make a big incision. So people are in the hospital for a shorter amount of time compared to what an open operation would be, which is a big, big cut. So our typical surgery, a sleeve takes about 1 hour to 1.5 hours to perform in the operating room. You're in the hospital for a day or two, typically 2 days after that operation. And part of that is really to get used to your new anatomy and how it feels to eat, because it feels completely different. And we're obviously giving you medication for pain control. Physical therapists often see people in the hospital as well. So there's a whole lot of really teaching you how to take care of yourself and set you up for success when you get home. Gastric bypass is very similar in terms of recovery, but the operation itself takes about twice as long. As I drew earlier, it was a little bit more complicated operation. We're making 2 new connections, and that just takes more time. All operations are done under general anesthesia. You would not know anything that's going on during the course of the operation at all. And often not even really until you're in the recovery room will you start remembering things. And the last part of that question was when back to school. We like people to stay at home at least a week usually. So sometimes these operations are done more on school breaks. And a big part of that is what I just mentioned also, which is you getting used to anatomy and how it feels to eat and getting used to eating more frequently. Introducing school into that mix can make it a bigger challenge. It's the same recommendation I give to my adult patients. Take some time off work, because trying to do work and get used to re-eating is not a recipe for success.
Okay, a lot of things to consider about surgery, but it sounds like there are a lot of modern techniques that make recovery faster with the laparoscopic procedure and the sleeve, and a lot that goes into thinking about how it impacts a person long term. Dr. Heinberg, could you comment on a teenager? Who's the right candidate from a readiness standpoint for surgery? What qualities should they have and characteristics are important?
So whether adolescents or adults, there are certain things from a psychological perspective that we might think are contraindications and things that we would delay surgery until they're addressed. In adults, that's often things like smoking, but there are plenty of adolescents who might be vaping or doing other health behaviors that might impact outcomes. We also want to make sure that difficulties that might impact weight loss or put somebody at greater risk for weight recurrence, like a significant difficulties with binge eating, that those would be addressed prior to surgery. Those are, the same with adults. With kids or adolescents, we often want to make sure that they have a full understanding of what they're about to take on. These surgeries are largely permanent. There are so many benefits, but we want to make sure that kids also understand the risks. We want to make sure that kids understand some things that they may not have even thought of yet. These surgeries impact how people metabolize alcohol and make them more susceptible to intoxication. That can be something to think about with somebody who's finishing up high school and is about to go off to college, and how will they sort of negotiate these new challenges? A lot of eating is social, and do kids and adolescents really understand how this will impact them? Will they tell their friends? Will they not? So there are those considerations, and whether an adult or an adolescent, people do better when they have a lot of support, when they're in an environment that really supports the changes that they're making. And that is even more important for an adolescent who's not doing the shopping necessarily and is not doing the cooking or other things. I think the final piece, it's really important that ultimately this is something the adolescent wants. Sometimes parents may have had this surgery themselves and they see how much of a benefit they've received, and they don't want their kid to go through what they did. And they might be not even purposefully pushing it, but the adolescent might be feeling pressure. So we really want to make sure that they are fully ready to take on this life-changing and in a very positive way, but this life-changing decision.
Thank you, Dr. Heinberg. We do have a question that came in through the chat. Is obesity hereditary in some cases? And Dr. Alkali, could you address that question for us?
So I would say it's a risk factor. It's, as we said, as a complex disease, genetics would be always a higher. So it's actually an important factor, an important player. So if there's any family history of obesity, it's some part of it, it's actually could be hereditary. So just kind of would increase the risk of developing obesity in the future generations. So I would say it's one of the risk factors. It's not the only factor, it's one of them.
you feel like a genetic test is necessary, or under what circumstances would that be needed?
Yeah, so for the genetic, so like having a mutation or like a genetic, but basically a mutation, or like if there's any issues with your genes specifically that's causing obesity, which is kind of simply kind of different question. But generally speaking, we try to evaluate for genetic causes of obesity when we have certain behaviors or red flags that actually we can identify in these patients. So generally speaking, if a patient or a kid start to develop this severe obesity at a very young age, so anything before age of 5 years with severe obesity, that's kind of very worrisome for us. We have to see why is it happening so soon? Why is it happening at this very early age? Especially if the kid also is showing some sign of or like some abnormal food seeking behaviors or what we call hyperphagia. So if that kid is actually stealing food from other or like going through the trash to just eat food or just going and kind of talking about food all the time, throwing tantrums if they're not actually offered the food. So all of these factors that we try to evaluate for and we actually try to ask about during our initial evaluation, these two main things, having the severe obesity at a very early age and this having this abnormal food-seeking behavior, would be maybe our main causes to go ahead and say, yeah, we are maybe dealing with some type of genetic or like like a mutation that's causing this obesity. So we have to evaluate for it, and possibly for certain actually causes of this genetic or monogenic obesity, we have actually specific treatments for these kids.
Thank you, Dr. Alkali. Really, you've highlighted, again, the complexity of this condition, that it's a different condition in a different child. It's not all the same. And so really treatment and the evaluation have to be individualized. So thank you for your comments on that. I have a question for Kathleen, our physical therapist. What are your thoughts about the role of weight training for a child we're seeing for high body weight?
I think that exercise in general can be any type of exercise as long as you're moving your body. I think weight training, when it's done in a controlled setting and it's being done properly, I think is fine, but we would want to mix it up a little bit and get some aerobic activity in there as well. I think, weight training for children, should definitely probably not happen too soon either. And again, I would be concerned about risk of injury if the weight training was being done improperly or not under the supervision of somebody who understood proper weight training techniques. So yes, of course, building muscle strength is very good for overall health, and but you can do that through movement and for our younger children through play and playing sports and that kind of stuff as well. I hope that answered the question.
Yes, thank you. Sounds like it should be supervised if you're really using weights, but there are other ways to build muscle strength and in a fun and safe way also. But thank you. And Margherita of our dietitian team, Margherita, could you comment on the role of things like protein shakes, and what are your thoughts about keto?
Sure. So typically, depending on the age of the patient, we may consider using protein shakes as maybe a meal replacement, especially for our teens that are typically on the go or who may not be eating breakfast at all. So that may be a better alternative for them. For our younger kids, we try not to focus so much on diets per se and more on establishing regular meal patterns, increasing variety, and just trying to get them to try more foods. But every patient is different. But in Be Well specifically, we really try and not to label things as diets and more as a lifestyle approach.
Thank you. So really, I haven't heard from our panelists anyone say that it's a diet or, we're talking about a program for weight loss. It's really comes across as building habits and healthy patterns that are sustainable and that are enjoyable and not, that doesn't feel like punishment or work. So thank you for those comments about protein shakes and how we regard nutrition plans. Dr. Heimberg, I'd like to hear your thoughts about the impact, especially for teenagers, but also for young kids, about social media and TikTok, and what impact is that having on children? Does it have any relationship to the kind of work that our team does?
So absolutely, social media has an enormous impact on our kids and our adolescents, and it's not good when we look at the impact generally with mental health, that time spent on these types of platforms seems to be associated with worsening mood, worsening body image complaints, higher anxiety. And there is also a lot of bad information when it comes to eating behaviors and exercise on these platforms. And it is really, really hard to balance that out with good information. And so I'm, don't even know where to start when it comes to how this can impact body image and disordered eating. But it is the Wild West of bad information around how to lose weight. And it's very important that we do things like why we're here we're here tonight to, in a very, very small way, kind of balance out what is that good information. So for example, we, in the world of metabolic and bariatric surgery, patients can get all kinds of information. They can watch people's TikToks. They can go on lots and lots of different Facebook groups. But we think it's very important that we have our own Cleveland Clinic support groups that patients can come to. They always have one of our professionals there to help moderate, to make sure that people are getting the right type of information, to make sure that they're not hearing about dietary information that might actually be harmful. It is, I think, very important for families to talk about what their kids are hearing about. If their kid suddenly says, "Oh, I'm not going to eat this because I saw a TikTok that said that it is bad for you," have that conversation and learn a little bit more about how to be social media literate and how to be a very smart consumer of social media. And if your child in particular seems to be feeling worse from time spent on social media, either because of all of these bad images or information, or because of teasing or other things, it might be time. I will actually use the word diet. It might be time for a social media diet in order to balance that out.
Thank you, Dr. Heimberg. We have a question in the chat about surgery. Dr. Strong, how much does it cost for the average surgery?
That unfortunately is not an easy question to answer because these surgeries are always covered by, or they would be submitted to insurance. And everybody has different, even within the same company, different coverages for insurance. Our program does have what's called a navigation team, which is a group of people whose whole job is to help make sure that people are meeting insurance requirements before surgery. Making sure that all the documentation that is collected and created is submitted properly to insurance. And they're also the ones that will help navigate what those requirements are. There are cash pay options, but those are customized to the individual and not typically what we are seeing for the pediatric obesity population. That's really more for our adults, although if people are interested in, the same navigation team is the ones that set up those cash pay options.
Okay. Thank you, Dr. Strong. Well, we're coming up on 6:30 and there are no additional questions in the chat. So I would like just to draw our first virtual event to a close. And I want to thank all of our panelists for your dedication and presence here and contributions to this web event. And we look forward to having more on a periodic basis in the future. And I especially want to thank the patients, young people and their families who've joined us for this conversation. And you will get an email about how to make an appointment. And actually, I was supposed to show this. So let me just put up this QR code. And this just links to our Be Well website. But our philosophy is really to provide comprehensive and non-stigmatizing care. You've heard from our team members. We want to, this is a hard process and we want to make it sustainable and help families overcome the challenges that can arise as we go through this process. And we want to give the best care, state-of-the-art care possible. And that can include behavioral health, nutritional interventions, exercise interventions, and as needed medications and surgery for the right person and who's properly supported and prepared. So with that, let's close the proceedings and thank you all for attending and have a great evening.